Hi everyone, good afternoon. I hope you guys are doing good. Hi, am I audible and visible, guys? Okay, thank you. Thank you everyone. And I'm so sorry we are late. We were just going online on YouTube. Now we are streaming on YouTube as well. Hello guys from YouTube as well. Good afternoon, everyone. Okay guys, so let's start. I welcome you all to this induction program of our Diabetes Master Course 2023. And I would like to thank again Geetanjali University and Geetanjali Institute of Pharmacy Udaipur for the collaboration and the affiliation. This course is affiliated with Geetanjali University. The certificate, what you are going to get, the master certificate and the series certificate, what you are going to get will be affiliated from the Geetanjali University, Udaipur and Geetanjali Institute of Pharmacy, Udaipur. And I would like to thank Professor Mahendra Singh Rathore for making it easy for us. Dr. Mahendra Singh Rathore is the principal at Geetanjali Institute of Pharmacy, Geetanjali University, Udaipur. And I would like to thank all of you, all the participants of this course series. So I'll come to that course series as we have planned the 3 series. Okay, so in this there'll be no 4 or 5 series. There'll be only 3 series: S1, S2, S3, and whoever is completing all 3 series with us, whoever is completing all 3 series is with us, will get the master certificate course. See, everyone will get the certificate. See, if you are participating in series 1, you will get the certificate for series 1. If you are participating in series 2, you will be getting the participation certificate for series 2. If you are participating in 3, you will be getting the certificate for that also. So don't worry about the certificate. That once you are completing the series, you will be getting the series completion certificate. But whoever will complete all 3 series will get master certificate course in diabetes. Okay, I mean master certificate in diabetes, right? As this is the diabetes master's course, right? So they will get the entire 1 year certificate separately from your 3 series certificates. Okay, as we are running multiple courses for oncology, we have in cardiology, we have in gastroenterology. Recently we have finished the second part, and in cardiology recently we have completed the third part. Still there are 2 more parts in cardiology. There are 2 more parts in in gastroenterology. Okay, so there are multiple things, but in diabetes, we thought to include only 3 parts, and we will try to complete in all 3 parts. And guys, let me tell you, this course till now there are around 350 registrations. 350. Okay, I can see there are only 87 people joining from Zoom, and there are some 15 people joining in the YouTube. But still, okay, okay, so yeah, but there are 350 people who have registered for this course. Okay, so this is always, as always, CLIMAD has been trusted by people, and they are registering with us. They are coming to our courses, and it's always overwhelming for us, overwhelming for me. So guys, I'm Dr. Ajit, CEO and founder of CLIMAD Research Solutions, and I am here to take your induction class today and the entire course, because cardiology and diabetology are my specialties. So I did my PhD in cardiology, and then still I'm serving in cardiology in multiple projects and multiple things, but I shifted to diabetology as I got the responsibility from Indian Council of Medical Research to handle the diabetology at Kasturba Medical College right now as scientist C. So I'm handling the diabetology and young diabetes related projects at KMC and 12 other hospitals in South Karnataka. So, that's why diabetology is my new favorite area. And my new concern, as everyone's is. So I'll be taking all your classes along with few other eminent speakers. You'll be seeing in our upcoming classes. We have Dr. Shivani Desai from Serum Institute of India. We have multiple other people who will be taking the classes for you, and mainly I'll be taking the classes for you as well, right? For the entire diabetes series. Okay, this first series. Later we'll see. Depends on the course curriculum and depends on the course syllabus as the university and studying. Right. I request everyone to mute your mics. Okay, please mute your mics, everyone. Okay, so guys, let's start. Let's not wait much. Again, I welcome you all and thank you all for joining this course. And today we are going to learn a lot of things. And as this is the induction program, we usually don't take any technical class or don't cover any kind of syllabus in induction class. But as this is a webinar also, okay, this is the part of our pre-webinar series also. So this is the episode 3 of our CLIMAT's free webinar series, and here we are talking about the global impact of diabetes. Okay, global impact of diabetes on people, on population, and we are going to learn a lot of new things, lot of new facts with lot of questions and queries. So before we start the class, before we start the session, let me ask you, let me test you, like how much do you know about diabetes? There are 5 questions, and in these 5 questions, you have to answer. You can speak, you can write, you can mention in the chat box, you can mention in the YouTube chat box, in the YouTube comments, live comments, and you can tell us. Okay, and then I'll be going to the class with the justifications. And in today's class, I'll be covering the entire global impact along with the pathophysiology and the types of types of diabetes, classification of diabetes and their impact globally, right guys? And then we'll be completing the thing. So let's start. Okay, let me share my screen, guys, with you. So okay, I welcome you all again to the Diabetes Masters Course 2023, and today is the induction program and the episode 3 of the free seminars, free webinars from CLIMAT. So today's topic is impact of diabetes and the global scenario. We are going to discuss global scenario, right? So let's check out your knowledge. Let's test how much do you know, and then we'll be discussing all the global scenarios. I have collected the data from the latest articles, from latest guidelines and latest reports worldwide, and you will be surprised to know the results, and you will be surprised to know the facts about diabetes today. Okay guys, for sure, I'm very sure. So let's learn about diabetes. Let me okay, I hope the full screen is visible to all of you guys. If I'm not, is it okay? Yeah, perfect. Thank you very much. Thank you everyone, thank you very much. So okay, so there are 4 questions related to this. Okay, this is the first question actually, and there are 4. Question number 1 is, in this course of type 2 diabetes mellitus development, in the course of T2DM development, which of the following actions are associated with which organ or tissue? Okay, there are 4 actions. One is decreased glucose uptake, one is decreased incretin effect, one is increased glucagon secretion, and one is insulin resistance. So what do you think IELTS alpha cells are associated with which action? IELTS alpha cell is an tissue or cell. Okay, so which action is associated with IELTS alpha cells out of these 4 guys? Please answer. Please tell me which one. 1, 2, no. 1, decreased glucose uptake. 3, which one? 1, 3, which one guys? Which one? So majority of the people are talking about 3. 3, okay. 4 is 1. 1 is quite a good number. 3. So you are telling that increased glucagon secretion is associated with IELTS alpha cells. So let's check. Yes, 3 is the right answer. 3 is the right answer. Increased glucagon secretion. Okay. Question number 2. Liver is associated with which axon? Here. Now definitely you cannot say 3 because 3 is over. Okay, but it could be. I mean, it could be. You can your answer depends again on your knowledge. Liver is associated with what? Increased glucagon secretion, decreased incretin effect, or decreased glucose uptake, or insulin resistance. 4141. Oh, a lot of one are there. I'm literally confused. Wait, guys. So wait, I have the wait. Just wait for a second. Answer, no problem. Wait for a second. I have another option here. I'll just write the. I'll not write the entire thing. Okay. I'll just write the liver and 1, 2, 3, 4. Okay. 1, 2, 3, and 4. You just have to choose 1, 2, 3, 4, either of yes. So liver is associated with what? Tell me, guys. Poll is here. Now I'll easily understand like how many of you know that. Oh, answers are almost similar, 50% and 44%, 51, 53. Okay. Yes, guys, what do you think is the right answer? Decreased glucagon uptake or insulin resistance? I mean, majority of you are voting for this only, right? Okay, please, guys, everyone, only 51 have, selected the answers out of 92, 93. Everyone. Okay, so let me show you the answers. Let me show you the results. What did you say? Okay, see, you have selected 56% are saying that decreased glucose uptake is associated with liver, right? 56% and 36% think insulin resistance is associated with liver. Okay, so let me show you what is not. So right answer here is insulin resistance is associated with. So here the 36% people were saying that liver is associated with insulin resistance, and that's perfectly correct. Insulin resistance is the right answer. Okay, guys. So now tell me, GI tract is associated with what? Let me share the let me launch one more question here. So now you know GI tract and same answers will be there, right? So I'll just share GI tract. Question 1, answer 1, answer 2, answer 3, and answer 4. So ready? Yes, guys. So yes, answer. Answer, guys. Yes, guys. What's the answer? Okay. So 72% people says that answer is decreased incretin effect. Okay, let me show you the results, guys. Share the results. So what did you say is the result? Okay, 71% people says that decreased incretin effect is associated with GI tract. Okay, and only 14% says decreased glucose uptake. Okay, let's see then. Let's see what's the right answer, guys. Yes, decreased incretin effect. So I think it's very clear now. Okay, but still, there is a last question associated with this, and that is skeletal muscle. So here is your, next poll. Here is your next poll, guys. Oh, still people are selecting the other answers. Come on, guys. Yes, I can see the YouTube as well. Okay, wait, let me see in the YouTube. Yes, guys. Okay. So, absolutely, you have the decreased glucose uptake. Answer number one is the right answer. Right. Answer number one is the right answer. Right. Decreased glucose uptake is associated with skeleton or skeletal muscles. So now next question, number two. Question number two for you is here. According to the American Diabetic Association and the World Health Organization, what are the cutoff values for diagnostic diabetes? How would you diagnose the diabetes? What would be the cutoff values for fasting plasma glucose? And what would be the cutoff values for HbA1c? What is the right answer, guys? Please tell me the right answer. C. C. 2. 2, 1, 2, 1, 2. You have to answer in 1 or 2. I mean numerics. 3. Oh. Read correctly and tell me, guys. First, read the question. What are the cutoff values of FPG and HbA1c to diagnose the diabetes according to American Diabetes Association and the World Health Organization? Okay, 2, 3. Oh, people are saying 3 also. Are you sure, guys, that 3 also? Oh, many are saying 3. Oh, you have to upgrade your knowledge, guys. That's why we are here. So right answer is 2. FPG fasting plasma glucose must be 126 mg per dl and HbA1c should be less than or equal to 6.5%. 6.5%. So can someone tell me what is pre-diabetic situation here? Can someone tell me? Today we are not going to take diagnosis, but can someone tell me what is pre-diabetes? When we say the patient is pre-diabetes. Yes, guys, please tell me.
When it is 6 option, as per option 3, you can say
When it is as per option 3.
3.
Okay. So pre-diabetes is when your FPG is somewhere between 108, I mean FBS, what we say in India, that is FBS fasting blood sugar, that is somewhere between 108 and 126. Okay, when your blood sugars, fasting blood sugars are between 108 to 126. Less than 108, everything is normal. Okay, and when we talk about HbA1c, it should be 5.7, 5.7 usually to 6.5. Okay, 5.7 to 6.5. Some guidelines says 5.5 to 6.5. That is pre-diabetic situation. 5.5 to, usually some says 5.5 to 6.5, some says 5.7 to 6.5. Okay, I mean, depending on the different studies and different AUC's, area under the curves, and significance, and what they're checking, significance and all, area under the curve, and also that depends on different large studies. And that's why usually American Diabetic Association and World Health Organization, they take 5.5 to 6.5, and FBS somewhere 108 to 126 mg per dl, right guys? So that is the thing. Question number 3 for you is, in the natural history of disease progression, which comes first? So after diabetes, what do you think? Microvascular complications comes first, or macrovascular complications come first? Tell me guys, what do you think? Which come first? Macrovascular or microvascular? Macrovascular are not coming first. So right, you all are right. First microvascular complications come, and then macrovascular complications come. Right, absolutely right guys. Okay, now please mute your mic if you're not speaking. Okay, otherwise we have to mute you guys. Question number 4 here is about epidemiology, okay, that we are going to talk. So what is the relative risk for death? What's the relative risk for death in people who have diabetes and cardiac disease, both coronary heart disease, both? Guys, tell me. If it is 3%, 6%, 9%, 12%, 15%. So what is the probability of dying people with diabetes and heart attack or other coronary artery diseases? Please tell me guys, what do you think is the probability or the relative risk? So let me tell you relative risk is actually the how many folds risk is getting higher, how many folds the chances of dying or chances of outcome is increasing, right? So tell me, what do you think it would be when it comes to diabetes along with coronary artery disease? Yes guys, 12% people are thinking so high. Okay, so the right answer is 6%. Okay, and that is also not the precise answer. So right precision, what we say, the precision of these relative risk between for the diabetic patients with coronary artery disease is somewhere 3.5 to 5.5%, but some study says it is 5.5 to 6.7%. Some study says, so majority of the studies are around 5 to 6%, and that's why we keep it the national registries. They say that the risk of diabetes and heart attack lead to death. Okay, risk of death in diabetes plus coronary artery disease patient is around 6%. Okay guys, it is around 6%. So it is around 6%, but that is not the precise answer. Precise answer is somewhere that is a range. Okay, that is a range somewhere between 3.5 to 6.5, 6.7%. Okay, so last question for all of you is, what proportion of people with diagnosed diabetes already has kidney disease? So what do you think? The question is altered a little bit here. You please try to understand and tell me. So here I'll simplify the question for all of you. How many or how much percentage of chronic kidney disease people get diabetes? Simple. or how many diabetes patient, or what is the what we say, the percentage or incidence of chronic kidney disease in diabetes patients? Okay, simple question, not tough. Oh no, you guys are very vague answers here. 1 2 3 4. See, 1 2 3. How would I know what is the right answer? Please tell me. Okay, let me, come on guys, make it simple now. Yes guys. It's very tough. Okay, I'll make it simple. I'll make it more simple for you guys. Okay, I'll, so the lifeline, I have removed one answer. Okay, I have removed one incorrect answer, that is 50%. Okay, I have removed 50% answer. Now you can tell me the correct answer. I have given you one lifeline here. So this quiz is pre-course assessment. Okay, this quiz is pre-course assessment, and I have the records now. So after the course, again we will have the same quiz. Okay, after completion of the course, again we will have the same quiz and we'll see how much did you learn. Okay, and this quiz will not be the final examination. After this course completion, you will be having a final examination, and there will be 20 to 30 MCQs, and you have to clear the exam one attempt only. You have to clear the exam with 60% of the marks. 60% of the marks. See, here the results are very, very vague. So the highest percentage is 38% for 20%, then 28% for 30%, 23% for 10%, and let's see, you only see guys. Why I should show you. See the results. Almost everything is equal. 20% and 30% have the equal results. 38 and 30 and 23 and 10%. Okay, right? So this is your answer, guys. Okay, so let me tell you now. The right answer is 30%. Okay, right answer is 30%. What percent it is? Actually the precision, this is a round figure. The precision, what we say, the precise result or precise incidence of chronic kidney disease in diabetic patients are 28 to 35%, usually 28 to 35%, or lesser than that, I mean 35%. Okay, and in some I mean, depends on the studies, number of the studies, but bigger studies and multi-centric studies, worldwide global studies says, the global report says that is 30%. Okay guys, that is 30%. So the right answer here is 30%. Let me see what the YouTube people says. Okay, they're also right with us. So look at this now. Let's come to the point. This paper, this newspaper, and this cutting has recently come. Okay, and you must be seeing everywhere in the LinkedIn, in newspapers, in TV, in in the news, everywhere you will be seeing that we have crossed 100 million diabetic patients in India. 100 million diabetic patients in India. Yes, this is true. Right now we have 100 million people with diabetes in India. Okay, and this has increased by 44% in last 4 years. This study has come from ICMR. So ICMR has conducted a big study in 1,70,000, somewhere 1,70,000 patients, and then they came to this conclusion. They found that there are 100 million plus Indians who are diabetic. Okay, and if you look at the right figures here in the table, state wise, not only this, the 100 million plus diabetes, but there are 36% hypertensive also. Okay, in these 100 million patients, there are 36% are hypertensive. Okay, so almost 36 million out of these diabetic patients are hypertensive as well. Got it? And then if you look at the states, 10 worst affected states are these. First is Goa. Goa. Okay. Goa has 26.4% population with diabetes, and 20.3% population is in the stage to get diabetic. They are in pre-diabetic stage. Goa. Okay. So around 50% of the people, 40%, or we can say 46% of the people are in the pre-diabetic or diabetic stage. 46% people. Okay. Look at the Puducherry. 26%, 26.3% are diabetic right now, and 18% are at the urge of being diabetic. Chandigarh, 20.4%. These are very dense states, or dense, what we say, the cities. The population is quite high, right? And then look at Delhi, 17.8%, and 18% are at the verge of getting diabetes. Then Tamil Nadu, 14.5%. West Bengal, 13.7%. Sikkim, 12.8%. Look at the pre-diabetic stage here. Sikkim and West Bengal, their diabetic situation is like 13.7 and 12.8% respectively. But look at their pre-diabetic population. In Sikkim, pre-diabetic population is highest, 31.3%. In Sikkim, the pre-diabetic population is 31.3%. And in Tamil Nadu, it is 10.2%. In West Bengal, it is 23.5%. Puducherry, 25.8%. Look at the pre-diabetics. In pre-diabetics, Sikkim is at number 1 with 31.3%. In diabetics, Goa is number 1. Okay. So this is the current scenario of India in diabetes. Look at this. While around 11.4% of India's population is diabetic, 15.3% are pre-diabetes. Right now, 11.4% of Indian population is diabetes. Can you imagine? 11.4%, almost 12%, we'll say round figure, right now are diabetic. I mean, 12 people out of 100 are diabetic. And they're not talking about adults. They're talking about everyone, including child, elder, male, female, everyone. So it is a dangerous situation right now. Ratio of diabetes and pre-diabetes is around 1:1. Okay. And see, look at this, another scenario. I'll show you guys here. Pointer, where's my pointer? Look at this. 81.2% people out of this population, whatever they have studied, they have predicted out of this 100 million plus diabetic patients, around 81 are general obese patient. Okay, they are under the general dyslipidemia. Their cholesterols were high, cholesterols were abnormal. Can you imagine? What is the major reason for heart attacks? What is the major reason for diabetes? What's the major reason for other problems? Cholesterol. Ineffective lifestyle. Okay, the sitting lifestyle. If you are not active, okay, the main thing in India to get all the problems is sedentary lifestyle. Okay, just going to the office, sitting on the chair, coming back, sitting in front of the TV, watching match for 6 hours or 4 hours, not having a single minute to go out and work out or park or to play football or to play a basketball or anything. The sedentary lifestyle and the work stress, right? That Note it. Sedentary lifestyle and work stress are two major reasons in India for the heart attacks and diabetes and other major problems. These two reasons are major. Okay, and that's, I'm not saying, that is by the studies. Okay, so this is India's scenario. Now let's come to the other part. Recently this paper was published by Dr. Mohan and his team, the ICMR, India Diabetes team has published this paper recently in Lancet. Okay, in Lancet they have published the India's health report, non-communicable disease health report. And Lancet is Lancet endocrinology, where they have published health and endocrinology. This has impact factor of 45. Okay, so they have published this report in impact factor of 45 journal. Lancet is very famous journal. And recently, a month back, not even a month back, it has not come yet completely online for everyone, this paper. So this paper you can read. It's very interesting paper. You must read this paper, I'll say. Metabolic non-communicable disease health report of India, the ICMR IND-IAB. So IN is India, DIAB is diabetes. India Diabetes National Cross-Sectional Study. Okay, they have published, and this study was going on from 2008. I'm also the part of this study. And I'm taking care of the young diabetes patients. Okay, ICMR YDR, Young Diabetes Registry. Okay, so this is the study what was going on since 2008 until date. They have, in this cross-sectional analysis, they have analyzed 1,13,000 individuals, and based on that they have predicted all the numbers and all the incidences and all what you are seeing here. So it's important to look at those parts, right guys? So now let's go to the scenario worldwide. What is the scale of diabetes worldwide? Can someone tell me which country is on the top in having diabetic patients? Can you write your answer or say?
UK.
USA, India. Okay, writing. USA. Okay, guys. Yes, please say me. Please say some more. India, USA. Wrong. All wrong. Okay, you all are wrong. China is number one. China is number one in having diabetes, and right now China is having 146 million diabetic patients. China is number one with 146 million diabetes patients and around 120 million pre-diabetes patients. 146 million diabetic patients and 120 pre-diabetes. Okay, but in India scenario is different. Here in total there are around 120 something diabetes. Prediction means the calculation says that there are 120 million diabetic patients and 136 million pre-diabetes. Ratio is 1:1 only, but the pre-diabetes situation is more in India. 136 millions are pre-diabetes. You can see in the last paper also. See, it estimates pre-diabetic population around 136 million in India. Okay, so this is here. Worldwide in 2015, there is no recent reports on this. In 2015, there were 415 million diabetic patients, and it is estimated to increase by 55%, and it is reaching to 642 million. 642 million by 2040. In next 15 years or 16 years, in next 16 years, it will be reaching to 642 million. Actually, it will be crossing 700 million in next 15 years or 16 years. Okay, so this is the scenario worldwide. And where are the hotspots? Can you tell me second number? Can you list down top 3 countries with diabetes, guys? Top 3 countries with diabetes. One is China.
Top 1 China, top 2 India.
China, India, and yes, guys, right. I'll tell you the hotspots. China, India, Pakistan. Arey, no, yaar. Pakistan doesn't have this much, diabetes. Sure. Okay, so see, look at this. Where are the diabetes global hotspots? Look at this. The number one is China. I mean, this is a 2015 report. So right now there are 146 million Chinese patients, Chinese people who have diabetes. 146 million, and India is right now 120 million. This is 2015. Okay, but still, this remains the same since 2015. China is number one, India is number two, and then USA is number three. Okay, USA is number three, and right now USA has 78 million. They have increased three folds. Okay, they have increased three folds. USA right now has 79 million diabetic patients. Can you imagine? India is 126 around. China is 146. USA is 79 million patients. So number one is still is China, number two is India, number three USA, and then others. Russian Federation, a lot of there. Mexico, Brazil is there. Bangladesh is, being a very small country, Bangladesh and Indonesia are having very large number of diabetic patients. Okay, their incidences are quite high. Okay, guys. So these are the global hotspot for the diabetes. Okay, just don't look at the numbers because these are 2015. But now also, this is the exact scenario. After 7-8 years, this is the exact sequence. Okay, China, India, USA. Right now, next, let's come to the point. Where we are going to think the classification of diabetes, guys. So what do you think are the types of diabetes? What do you think, guys, are the types of diabetes? Tell me. And their reasons also, you have to tell me why are these happening, guys. Please write. YouTube people also can write, and they also can contribute to the answers. Please tell me, guys, what are the types of diabetes you know? And
Type 1 diabetes, type 2 diabetes, maturity onset of diabetes, gestational diabetes.
Gestational diabetes. Okay. Anything else, guys?
Maturity onset of diabetes.
Maturity onset of diabetes. Okay. MODI. What is MODI, guys? Can someone tell me what is MODI?
Majority onset of diabetes in young patients.
Maturity diabetes. Yeah, maturity onset of diabetes in young patient. Okay. And what is LADA? Can someone tell me what is LADA? Did you hear of the term LADA? I taught, if you are my students from past diabetic course, you must know.
Autoimmune diabetes.
Autoimmune?
Diabetes.
Yes, latent autoimmune. Latent autoimmune. What is the full form? Diabetic in adults. Okay, latent autoimmune diabetes in.
Latent autoimmune diabetes in adults.
Yes, latent autoimmune diabetes in adults. Okay, and what is gestational diabetes?
The diabetes will be suffering during the pregnancy.
Okay, diabetes in pregnancy, right? Okay, then any other type? Do you think, based on the causes, do you think drugs are also a reason for diabetes?
Yes, some steroids.
Steroid induced diabetes. Yes, there are multiple problems. There are multiple drugs also which causes the diabetes. Like steroids are main, steroid induced diabetes, right? Steroid induced diabetes, and antipsychotic drugs are also responsible for diabetes. Okay, other than this, any other thing or other reason or other etiology for the development of onset of diabetes? Do you know?
Pancreatitis problems also leads to diabetes.
Pancreatitis. Okay. Pancreatitis. Okay, so that is called chronic pancreatitis, and the chronic pancreatitis is also one of the type of diabetes, major reason of diabetes. So ICMR has included chronic pancreatitis in the category of diabetes recently. Okay. Other than that, any other cause virus, bacteria? COVID onset diabetes. Did you hear COVID onset diabetes? Did you hear about COVID onset diabetes, guys?
Yes, sir.
Yes. So after COVID, I mean, not only COVID, but there are other, viruses and bacteria which causes, diabetes. But after COVID, there are multiple incidences, and a lot of patients are coming with the onset of diabetes, new onset of diabetes, right? So this is again one of the major cause of diabetes. So let's see what are the types of diabetes. First is type 1 diabetes. Major is type 2 diabetes. Can someone tell me what is the percentage of diabetes 2 and 1? Percentage means distribution of these diabetes in population. Suppose there are 100 patients of diabetes. How many patients will be type 2 diabetes? How many type 1 diabetes? How many will be hybrid form or any other form? Let's decide it into three. Divide it into this. Divide.
80% type 2.
Type 1 5% and 90% type 2.
Okay. Yes. So it is like somewhere around. It's an old report which says 90 to 95% was type 2 diabetes. But that is not the recent report. Recent report says that the number has come down from the 90. Okay. Type 2 is around 87%. Type 1 is around 10%. And 3% are rest of diabetes. 3% are rest of diabetes. Remember one thing, gestational diabetes is not included in type 1, type 1 or type 2. Okay. But gestational diabetes could be either type 1 or type 2. Remember that. Very important to understand. Okay. Gestational diabetes, why we say it gestational? Because it is occurring during the pregnancy. The hyperglycemia. Okay. That is the hyperglycemia, increased levels of sugar, increased levels of plasma glucose during the pregnancy, due to the pregnancy consequences. That is called as gestational diabetes. That could be either type 1 or type 2. That could be stratified only. Remember the fact, everyone, remember the fact that could be stratified into 1 or 2 if it is persistently occurring after the delivery of baby. If it is persistently occurring after the baby delivery also, after the delivery also, then it can be stratified into type 1 or type 2. Usually in maximum patients, like 60 to 70, 50 to 60% of the patients, it recovers. Okay, the hyperglycemia recovers after the delivery. But if it is not recovering, then it can be stratified into type 1 or type 2. Got it? In 30 to 40%, it carries away even after the pregnancy and it gets permanent diabetes. Okay, great. So type 1, as we can see here, is either autoimmune or idiopathic. So maybe due to the unknown reasons or genetic. Okay, majorly it is genetic or it is with unknown reasons. Okay, that is idiopathic or autoimmune. Or autoimmunes are autoimmune imbalances could be one of the reason for type 1 diabetes. Type 2 diabetes, we are well known about this. It is happening because of insulin resistance. And in type 1 diabetes also, insulin resistance and dysfunction of beta cells occurs usually, because that is the ultimate goal of the development of diabetes. When the beta cells are dysfunctioned or destroyed, and it leads to insulin resistance. But that is the major and direct phenomena in type 2 diabetes. But in type 1 diabetes, that is indirect phenomena. Indirect phenomena means it is triggered by either autoimmune problems or it is triggered by the genetic problems or genetic abnormalities. Okay, or some unknown reasons. Understand? Type 1 diabetes also leads to the dysfunction of beta cells only. because the final thing from where the sugar levels will increase, from where the glucose levels, plasma glucose levels will increase, that will happen only after dysfunctioning of beta cells or insulin resistance. Okay, but in type 2 diabetes, that is a direct phenomena, okay, that we are reading, what we are going to discuss in the next slides. But in the type 1 diabetes, that is not the direct phenomena. Direct phenomena is like these are triggered by either autoimmune problems, autoimmune suppression, or genetic problems, or some unknown regions. Understand? So that is the difference between type 1 and type 2. Etiology means the cause of the problem, reason for anything. Okay, reason for the problem, reason for the consequence, reason for this disease. Etiology means the cause of the disease. Okay, so here you understand type 1 and type 2, then it is hybrid forms. There are multiple hybrid forms like immune mediated diabetes for adults, and there is ketone prone diabetes, ketoacidosis and all. Those are different, those are included in others. And other specific types are monogenic beta cell defects, or drug induced diabetes, as I was talking, infection induced diabetes, and there are some other defects induced diabetes. Okay, those all come under other specific disease. Then unclassified, there is no specific thing, only 0.0001% people, but that is like where you don't know the reason. These all are not the reason for that. And then there are two things, another part. One is gestational diabetes, and this gestational diabetes which is happening in the pregnancies, that is called the stress induced diabetes also, or not stress induced, sorry, pregnancy induced, but pregnancy stress induced diabetes it is called as. Okay, that is known as gestational diabetes. And can someone tell me what's the difference in diagnosis of normal type 2 diabetes and gestational diabetes? How you diagnose the gestational diabetes? The proper procedure, full. Yes, everyone.
OGTT, oral glucose tolerance test.
Oral glucose tolerance test. Okay, explain it a little bit, though in next class I'll be taking the diagnosis of diabetes, but still, what will be the procedure of OGTT? Okay, I'll take this in next class. So it is usually we give 75 grams.
25 grams.
Yes.
50 grams of oral glucose load followed by a 1 hour glucose measurement.
Okay. Yeah, and then we check the glucose levels in the
After
plasma.
1 hour, we will check the glucose tolerance in that
Glucose
person.
tolerance in the blood. Yes. So OGTT, I'll take the entire class on the diagnosis. No worries, don't worry. Okay, so this is the classification of diabetes, and after that, let's go to the pathophysiology directly, and let's try to understand one by one. First, type 1 diabetes. What's type 1 diabetes and how it happens? First, as I told you, there are two reasons. Either one is autoimmune suppression or other factors like environmental factors, and one is genetic predisposition. Okay, genetic predisposition means the imbalance in the genes, or gene defects which are causing the type 1 diabetes. So how it goes and how it leads to the diabetes. Let me show you with pointer. So if there is genetic predisposition or any other factor that leads to autoantigens formation on insulin producing beta cells and circulate in the bloodstream or lymphatics, that means here autoantigens are produced, autoantigens are activated by the help of autoimmune suppression, or the any other factor, or these gene or genetic imbalance or genetic defects or environmental factors or autoimmune suppression activates the antigens. Okay, antigens, it is producing or activating, that is now circulating entirely in the body. Okay, and then these are going to different parts of the body and activating the T helper cells 1 lymphocytes and activating the T2 T helper cells 2 lymphocytes, and T helper cell 1 lymphocytes are leading to the with the help of IFN, and interleukins 2, these are activating the macrophages, and these are activating the T cytotoxic CD8 cells. Okay, and in other phase where it was activating the T helper 2 lymphocytes, I mean T2 cells, it is now the with the help of interleukin 4, it is leading to the activation of B lymphocytes to produce the IELT cell autoantibodies. IELT cell autoantibodies means and anti-GAD65 antibodies. So these two, will be opposing the insulin generating beta cells. Okay, insulin generating IELT, cells. It will be opposing and it will be destructing those. So the final phase, again, as I was telling, indirectly it is leading to the destruction of beta cells with decreased insulin secretions. So where are these beta cells are located, guys? Can someone tell me where are these beta cells located?
Cycles of Langerhans.
Pancreas. Yes. Also of Langerhans, yes, that is in the pancreas. Okay, that is in the pancreas. Yes, it is in the pancreas. So simple, wherever you feel, I mean, when in the type 1 diabetes, the main etiology is either genetic, default genetic faults, or environmental factors, or autoimmune disorders, which actually activates the, antigens for insulin producing beta cells. And then they are going and in pancreas they are activating the T helper cells 1 lymphocytes and T helper cell 2 lymphocytes. So with the help of IFN and interleukins 2, T helper cell ones are again activating the antigen specific for CD8 cells, and with the help of IL interleukin 4, these T helper cell 2 lymphocytes are generating or producing or activating the B lymphocytes to produce the IELT cell antibodies, okay, or anti-GAD65 antibodies. So these are the main reason for the destruction of beta cells in pancreas. Okay, so can someone tell me where exactly we do the GAD antibodies testing? For which type of diabetes diagnosis we go for GAD antibodies GAD antibodies? Yes, guys. GAD antibodies are a specific type of diagnosis. Are you sure it is type 1? Because we are studying type 1, that's why. See, GAD antibodies are differentiating. GAD antibodies are differentiating MODY and type 1 diabetes. Okay. GAD antibodies are to diagnose the MODY and differentiating the MODY from type 1 diabetes. Understand? Okay, so this is the type 1, and type 2, if you see, it is so look at this, guys. Look at this. Here they have defined in the Nature article where I was reading, they have very well defined the difference between Indian and Chinese population. So in Indian population, the first phase of insulin secretion is suppressed in the pancreas by the known reasons. Okay, and automatically it is decreased the first phase insulin secretion. But in Chinese population, in pancreas, it decreases the first phase and second phase, both type of insulin secretion. Okay, can someone tell me what is this one type, or phase 1 and phase 2 insulin secretion? Can someone tell me what is this, guys? What is phase 1 and phase 2 secretion? Phase 1 and second phase, first phase or second phase insulin secretion? In pancreas, beta cells. Okay, so let me tell you. let me tell you what is first phase and second phase insulin secretions. So insulin secretion from the beta cells is biphasic mechanism. Okay, biphasic mechanism means there are two phases. Okay, first phase is called as rapid phase. Okay, first phase is called as rapid secretion of insulin, and it takes place only for 10 minutes. Okay, it takes place for 10 minutes, followed by 3 to 4 hours of the second phase, that is the slower phase. Okay, first is like it is a constant process, includes insulin secretion is a constant process, but insulin secretion is needed when there are high ranges or when there are high level of sugar in the body. To combat that, we need insulin secretion. So wherever it is triggered, whenever it is triggered, usually every time we need insulin in the body, but whenever they have checked it from the onset. So from the onset, the process takes place in two phases. First phase is rapid phase. Okay, first phase is rapid phase, which takes place around up to 10 minutes, where the maximum of the insulin is secreted. Okay, and the second phase is led by the first phase. Okay, so first phase 10 minutes and second phase is up to 3 to 4 hours. Okay, where the slow secretion of insulin is happening. So why the first phase is very rapid? Because it combats the sudden increase of the glucose levels. Sudden increase of the glucose levels. Suppose you ate the sweet. Okay, suppose you ate a piece of sweet and it is going to your body, and suddenly it has triggered the beta cells, it has triggered the pancreatic beta cells, Langerhans, and you need insulin to combat the glucose levels in the body. So when there will be a sudden raise in the glucose levels, we need maximum insulins. So the maximum insulin release takes in the first phase, that is for up to 10 minutes, and then we need to control the sugar levels at the constant phase, and that constant phase is slower phase, and the slower phase takes place from 3 to 4 hours. Okay, that is called as second phase. So in Indian population, the first phase is suppressed, but in Chinese population both the phases are suppressed by the causes. Okay, in the pancreas both the phases are suppressed. That's why the highest number of diabetic patients are there in Chinese, and Chinese are literally, I'm telling you, Chinese are doing clinical trials, a lot of combating clinical trials to delay the second phase suppression also. Okay, so they are working on that. Definitely, wherever there is a wish, they can do anything. So these people are behind that. But why Chinese population or China is on number one in the diabetic population? Because they in the physiology, when we look at the type 2 diabetes in Chinese population, both the phases are suppressed. In Indian population, only first phase of insulin secretion is suppressed. Okay, in pancreas. Then in liver, insulin resistance is there in both the populations. And usually in Indian population, insulin resistance happens in the liver. The majority of the part is in the liver, and in Chinese population, it's in the skeletal muscles. And both are leading to impaired fasting glucose and impaired glucose tolerance and type 2 diabetes mellitus. Okay, guys, this is the type 2. Let's understand in the broader way. Diabetes type 2, involvement of the tissues and organs. So multiple organs are involved in type 2 diabetes mellitus, and their promotion of type 2 diabetes mellitus. So first let's start with the pancreas only. So in pancreas, hyperlipidemia is there, which is reducing the insulin secretion and insulin production. Hyperlipidemia is the cause of insulin secretion, and reducing the insulin secretion and reducing the insulin production, where hyperglycemia is happening because of these beta cell apoptosis and glucose secretion and alpha cell activities. So hyperglycemia means the beta cell destruction. Definitely it is happening because of the raise in beta cell apoptosis and glucagon secretions and alpha cell activities, and proinsulin and insulin ratio is increased, which is causing to hyperglycemia in pancreas and leading to the diabetes. Okay, other than that, there are many other intra and extra cellular amyloid accumulations. And when we go to from pancreas to kidney, there is diabetic nephropathy and risk of urinary tract infections as well. And in it can cause multiple problems and cardiovascular problems also, like hyperconstriction of microvasculature, and then risk of atherosclerosis, diabetic cardiomyopathy, diabetic autoimmune neuropathy, and multiple other problems. Okay, when it comes to the immune system is directly associated or directly responsible for IELTS beta cell destruction, because it is when your autoimmune is suppressed, immune system is suppressed, then it will directly lead, as we have seen in the last slide, will directly lead to the beta cell destructions. Okay, then adipose tissues. In adipose tissues, again, it will lead to hyperlipidemia and hyperglycemia. And why and how in adipose tissues, it will increase the pro-inflammatory activities and cytokine secretions, and it will decrease the lipolysis, fat storage, and glucose uptake. Okay, in brain and nervous systems, it will reduce the hypothalamic GLP-1R expressions, and it can cause diabetic neuropathy. It can cause premature aging also. In the brain, it can cause premature aging. Okay, and in liver, as we know, insulin resistance is happening, which is leading to the glucogenesis and fat storage and leading to the hyperglycemia. In skin also, it is causing multiple complications, like patients are at the risk of multiple diabetic complications, cutaneous complications, and they are on the risk of infections. In bones, it is decreasing the bone formation and increasing the risk of fractures. In digestive system, as we all know, in digestive system, multiple things are happening. So risk of esophageal complications are also there, gastroparesis is there. Okay, and it is also affecting or altering the gut bacteria. Okay, and the skeletal muscles, directly these are responsible for insulin resistance and metabolic inflexibility and atrophy, and leading to hyperlipidemia and hyperglycemia. So that's how the entire body is involved in type 2 diabetes. I'll share this picture in the group, you can read more. Okay, and then let's go to summarizing the beta cell failure. So beta cell failure or destruction or dysfunction is happening due to chronic hyperglycemia, and then glucotoxicity, and lipotoxicity. So these are the three major reasons which are creating the beta cell dysfunctions, and beta cell dysfunctions in pancreas. Majority of the things are this, like high circulating free fatty acids is leading to lipotoxicity, and lipotoxicity again is leading to beta cell destructions. Then here, if you see chronic hyperglycemia, maybe in pregnant women or multiple other causes, is leading to glucotoxicity and restricting the beta cells. Okay, due to that, there is over secretion of insulin to compensate for the insulin resistance. That is again the main reason of antibodies and leading to the destruction of beta cells. Okay, so you can see these two arrows are coming to pancreas and one arrow is going out of pancreas. That means lipotoxicity and glucotoxicity and high glucose levels and high free fatty acids are leading to the over secretion of insulin. That is leading to the antigen formation or antigen beta cell antigen activation and beta cell destruction. Okay, I hope it is clear, guys, for you. Clear?
Yes,
Anything
sir.
else? Yes. Okay, great. So now,
Pancreatitis causes diabetes, sir?
yes, it is. Pancreatitis means the cell destructions or damage of the pancreatic cells. Okay, so when pancreatic cells are damaged, means pancreatic cell also includes the IELT of Langerhans, and these are also including the beta cells. So pancreatitis means direct destruction of all type of cells, not only the beta cells but other cells as well. Okay, pancreatitis is affecting all type of cells in pancreas, not only the beta cells. So beta cells are also affected, and beta cells are also destroyed or inflamed. Usually, what does it mean by the pancreatitis? That is the inflammation of pancreatic cells. So all type of cells in the pancreas are affected and are inflamed. So that inflammation means the destruction, and that is reducing the functionality of beta cells and ions of Langerhans, and that is causing the high insulin secretion and activation of antibodies, and that is leading to the hyperglycemia or diabetes.
Thank you, sir.
Yes. Okay.
One more, what is why there is a difference in phase 1 and phase 2 between China and India, sir? What may be the
That
reasons
is
of
genetic. That is genetic. That is genetic.
genetic,
Yes.
or that may be the intake of diet? Or
No,
food?
see, that could be diet also, but usually genetic and genetic parameters or genetic profile are affected by the environmental factors as well, dietary factors as well, race as well. There are multiple things responsible for the genetic changes.
Okay, sir. Thank you very much.
Yes, thank you.
And one more, what is the pro-insulin, sir? Pro-insulin in pancreas.
Sorry,
I'd say the diagrammatic representation.
here.
Yes, pro-insulin.
Where it was in pancreas.
Pancreas. Pro-insulin
Oh
and
yeah.
insulin.
Pro-insulin and insulin ratio. Okay, so pro-insulin. Okay, pro-insulin is the the terminal phase of insulin, like before generation of the, what we say, before creation of the insulin or before developing into the insulin, because insulin is the hormone. Okay, insulin is the hormone. So there is a pre-phase and post-phase. There is like pre-phase means it will only develop to the major, what we say, the proper insulin. Okay, there are some more peptides. There are some more peptide chains, and that actually breaks into the insulin, exactly insulin molecular weight and all. So pro-insulin is the type of insulin, only type means the pre-phase of the insulin that is having heavy molecular weight, and heavy peptide chains. Okay, and once it breaks, it makes the insulin. So the ratio here for pro-insulin and insulin is affected. Okay, here pro-insulin is decreased and insulin ratio is increased. So when the insulin ratio is increased, definitely autoantigens, the antigens are formed to the beta cells to suppress the high secretion of that, and that is again damaging the beta cells. So the ratio of pro-insulin and insulin, because this is the pre-hormone of insulin. Pro-insulin is pre-hormone of the insulin. With the difference is heavy molecular weight and heavy chains of peptides.
Okay. Thank you, sir. Thank you very much.
Yes.
Very interesting presentation, sir.
Okay, so guys, now this is the summarizing tape figure here, and after that again, this is the course what we are discussing today. I think I should have kept this slide before. So this is the master's diabetic course what we are discussing. If anyone is interested only for today, they can register. Please circulate in your friends. Okay, only for today till evening they can register if they are interested, because in this entire course we are going to discuss a lot: diagnosis, biomarkers, diabetic complications and their impact. In this I'm not going to touch the treatment part. The basic treatment part will be touching, but here the most prominent thing is, as we can see, the name of this series one is strategic management of diabetes. Here we'll be talking about more practical things like diabetic complications, how they are impacting globally, and barriers to good glycemic control. What are the exact barriers? What are the like how we can tailor the treatments to the individuals? What are the algorithms also we'll discuss, but in the basic form only. But here we'll be discussing about the how we can tailor the management for individuals. Okay, and what are the evidences for early glycemic control? So this course is going to be very interesting for all of us, and we are going to discuss a lot. So guys, final quiz here for you. Final quiz. Please tell me one by one. Okay, I'm just, the answers are down. Answers are, downside, and there are fill in the blanks. Okay. So which action is associated with which of the tissue? First tell me GI tract. GI tract.
Decrease increasing effect.
Increased.
Decrease the incretin
effect.
Okay, decreased. Okay,
Incretin effect.
incretin effect. Skeletal muscle.
Skeletal muscle.
Decreased glucose uptake.
Glucose uptake.
Glucose uptake. Liver.
Insulin resistance.
Insulin resistance of increase of
Insulin resistance.
Adipose tissues.
Increased lipolysis.
Includes lipolysis. What one? Which one? Which one, guys?
Lipolysis.
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 Adipose tissue.
Brain?
adipose tissue.
Lipolysis.
Yeah, adipose tissues, lipolysis. Okay. Brain?
Diabetic neuropathy.
Yes. Kidney?
UTI.
Diabetic nephropathy.
Diabetic nephropathy, please.
Where is
Diabetic
UTI diabetic nephropathy in the answer? That's not there in the answers. Again, check for brain and kidneys.
Increased glucose reabsorption. Neurotransmitter.
Kidneys increase the
Neurotransmitter
glucose
Neurotransmitter
reabsorption.
Neurotransmitter dysfunction.
Kidneys
Neurotransmitter
increase the
dysfunction.
glucose reabsorption.
Okay. Pancreas?
Impaired insulin secretion.
Impaired insulin secretion.
IELTS, alpha cells?
Alpha cells, insulin resistance. Increasing insulin resistance.
Increased
Glucagon secretion.
Increased HGP, right?
Yes.
Yes, so HGP.
Okay. Let's see the answers, if you are correct or not. GI tract, decreased incretin effect. Skeletal muscle, decreased glucose uptake. Liver, insulin resistance, not IELTS of alpha. Or pancreas. Pancreas is impaired insulin, correct? Beta cell decline. Liver is insulin resistance decreased. And IELTS alpha are increased glucagon secretion. Okay, adipose tissues, definitely correct. Increased lipolysis. Brain, neurotransmitter dysfunction, absolutely. Kidneys, increased glucose reabsorption. Reabsorption is happening in the kidney. And pancreas, impaired insulin secretion, beta cell decline, and increased glucagon secretion is in IELTS alpha cells. Okay, so that is hyperglycemia, energic hematostasis. Okay, that is the final result. So with that, okay guys, thank you very much. We'll see you next week. Not next week, these classes. Okay, I want to ask one more thing, guys. Shall I take these classes on Sundays or Tuesdays evenings only? As I'm
Sunday will be good, sir.
Yes, sir. Sunday will be.
Sundays it will be the best.
Sir, what about pancreatic classes?
pancreatic classes are also on Sunday. So let's say, okay, so what time you are free on Tuesday evening, guys? 6 o'clock, 6:30 or 7 o'clock?
Around 6:30 to 7:30.
So Sunday will be better.
7, sir.
7 it will be okay, sir. If it is on Tuesday, 7 maybe we can, sir. Or preferably Sunday, sir. If not on Tuesday.
See, usually these classes were scheduled for Tuesdays.
Yes. I can
Right.
understand,
These
but
classes-
we are given the choice. We are telling.
Okay, fine. So let me think, if we see if there is no burden for all of you on Sunday, because Sunday we have pancreatic classes also. I mean CCBGH classes, we have clinical classes, we have medical coding classes, we have multiple classes. So let me see if it is not overburdened. I'll see when you can keep. Otherwise Tuesday 7 o'clock, 7 or 7:30 I'll keep. Or convenience to all.
Tuesday 7
Okay,
o'clock.
sir.
Tuesday.
Yes. Thank you. Then take care. See you guys. Bye bye.
Thank you, sir. Thank you, sir.